Welcome to another episode of Be Well with MS. I'm your host, Dr. Agne Straukiene, neurologist, and I'm thrilled to be joined today by Professor Jeremy Hobart, someone I had the pleasure of knowing and working with for many, many years. Professor Hobart is not only a phenomenal clinician, but also my mentor and trusted advisor. Over the years, we shared many insights about the MS community, and his dedication to his patients and research is truly inspiring. In this episode, we will dive into fascinating conversation about innovations in measuring health outcomes in multiple sclerosis, a topic that Professor Hobart is uniquely qualified to speak on. We will explore the evolution of measurement tools, how they've shaped current practices, and the increasing focus on patient-centered outcomes. Jeremy will also shed light on the global efforts to standardize these measures and how they are playing a key role in advancing personalized medicine for people with MS. Additionally, we'll discuss the ethical considerations involved in research and clinical practice. This promises to be a rich and insightful conversation, so let's get started. Welcome to this episode, Prof. Hobart.
Thank you very much for your flattering introduction. It's good to be here.
Yeah.
Even though we're 10,000 miles away.
Yeah, I know that you're currently in Australia, is that correct?
I am here at the moment, yes. I'm actually on a working holiday. So I've taken my holiday to be out here to be with the person that I was working with earlier this year and who I'm going to be working with later this year, who's an measurement expert based in Perth.
Fabulous. I have to say, for the listeners, finding the time with Jeremy is quite a challenge. Probably much easier to get to the moon and come back. But finally we found the time, and I have to say that I always go to Jeremy when I have bad times more often than good times, and I regret for that. But we really share various different topics and discussions, and we both participate at our regional MDTs and try to make very tough decisions for people living with MS towards the disease-modifying therapy, how to improve the quality of life, how to really improve patients' journey living with multiple sclerosis. But let's talk about the measurements today, because this is the hot topic, I think, and I guess we should start a bit of with a review of and sort of looking at the history and historical evolution of the measurements that is being used in MS research, and any sort of significant breakthroughs that have shaped current practices. So if we go back and look at how the research has been conducted and what measurements have been used and how it's sort of evolved over the time.
That's a very good point, because in some ways, the evolution has been relatively small in some aspects of measurement. So if we focus on clinical measurement tools rather than things like MRI, then what we see is instruments that have been around for many, many years. And I guess our go-to instrument is the EDSS, which stands for the Expanded Disability Status Scale. And the history of that is that was published in 1983, 41 years ago. And it was actually originally published in 1954 as a restricted version of it called the Disability Status Scale. So historically, our measurement instruments go back many, many years. And that has a number of implications. The first one is a positive one in that we see the common use of the same method through many different studies. And that, at one level, gives you some comparator. But the downside is that they haven't really taken advantage of the developments in measurement science. If you go back to the 1950s, then really the the developments were very limited, and they've all happened subsequent to then, and they haven't really been applied fully to the extent that they're valuable just yet. So we have this kind of interesting concept of advancing research processes, but historically less advanced measurement processes. And I guess if you reflect back on that, then the measurement issues are right at the center of our research, because they give us the numbers that we analyze to make judgments. And I think at the moment we've maybe missed a bit of an opportunity to advance our measurement processes and therefore advance our understanding, because it is very central. And I guess, so I was reflecting on this before we started, and thinking that in MS we deal with a disease that we don't yet know the cause. So we think we've got a good idea that it's a rare complication of Epstein-Barr virus. Our pathology is studied by intermittent examples of people who die early or brain banks, etc. So we can't get direct, real-time pathological studies of the extent that we want to, and so we're always on the back foot of understanding what's happening, and therefore we rely on manifestations and measurements to help us to guide our research. And therefore, the measurements are so central, so central. And I think, I'm afraid that they've held back some of our developments over time. I think if we're really honest about it, then I think we have our measurement weaknesses have probably held back our development of our understanding of the disease and our understanding of treatment.
So we're talking about the ancient measurement scale, which I haven't been born by the time it's been released and developed. And
no mention the first one.
And I think that you mentioned a very, very, very important aspects that, when we don't know the cause, how can you measure? When you don't know the actual root coming of this, like driving the pathogenism biology, how can you measure? But never mind, I just have to sort of hope for the future, brighter future, and everyone else listening us. And I think what is important for us, maybe there is a bit of a progress in this area. And are you aware of the latest innovations in measurement technique for MS, and how do they improve upon previous methods?
Well, maybe I painted a negative picture. There are lots of developments, and there are lots of developments all the time. And there is no doubt that there are advances in all sorts of directions. But I guess that the point in some ways that you've made about how do we measure things reflects on the fact that we haven't invested in that part of our understanding. So we've invested lots in treatments, etc., but less in the measurements. So what sort of advances have we had? Well, there's different types of advances. So there are types of advances in terms of things and ways of measuring things. So historically, we've measured from clinical assessments. Now we're moving more to patient-based assessments and also real-time performance indicators. So the focus on long-term ongoing measurements of people by smartphones and other indicators is a really important step. And I guess if we kind of think back about the way that we've studied diseases in the past, it's been intermittent measurements of things, whereas really it's the real-time, ongoing, continuous measurements of parameters that become important. And I guess one of the simple kind of exemplars of that is when you go into an ITU and somebody's wired up to machines, you see continuous readouts of their measurements. So you can follow the trends, you can see changes abruptly, etc. And that's in some ways what we're moving towards with the real-time measurements, which I think are really valuable. So those are just some of the things, and those are the instruments. Then there's kind of developments of at a methodological level, and some of this is because we try and construct measurements out of assessments. So clinical assessments, patient reports, etc., give you qualitative information. We then have to try and construct numbers that are bona fide scientific measurements from that information. And that is a whole field in its own right, which is complex, not well understood by many people in the clinical arena, and therefore we see methods that have been around for 50 years that are used much less than would be valuable to advance our understanding. So if we bring the subject back to one of your earlier comments, how do we deal with diseases that we don't know the cause of and the pathophysiology? Well, if you develop good measurement methods, you actually gain insights into those processes, and the circularity of that, of measuring and insights and understandings, develop both the measurements and the understanding of the disease processes. And that's how we advance in these circumstances.
Yeah, that's very insightful. I think to almost like look from what are the measurements and data of the human being's body that could give us a valid, valuable, deep insight into underlying cause of the disease. And to my understanding, correct me if I'm wrong, the measurement is in the format of data registries, MS base, MS registry. It's a measurement. It's collecting patients' data. Neurology assessment in our neurology clinics is another assessment that we collect the data of human being. So there are, to simplify that, if I could just categorize that into two categories, would be passive and active data collection, right? So passive would be by sensors, that we push the sensor into the shoes of someone's affected by MS, and we measure the step, the strides, the balance, the coordination. There are now AR tools that we are developing for the same matter. Apps that tracks the patient's steps and quality of sleep and blood pressure and pulse, etc., etc. And then there are active that requires participation of the patients to enter the data on the diaries, give us surveys that we send to patients. We call this patient-reported outcomes. So that's sort of is that correct? So that's an evolution of the measurements.
Yeah, I think that describes the situations very well. There are all these different ways of gathering information. And then I guess the question is, what sort of information does that give us, and how can we use it? So we can use standard measurement tools and gather information and analyze those. We've got qualitative information from patients and clinical assessments, but to turn all that into measurements is much harder, because you have to go through steps. So any assessment is just trying to gain an understanding of something, and then if you structure that, it becomes a structured assessment method. We tag numbers to it, and that's a beginning of measurement, but it doesn't actually provide you with measurements in the true sense of the word. And really, if we're going to analyze things carefully and understand, for example, longitudinal evolutions and the impact of diseases on rates of change over time, then we do need to move the quality of the processes and the quality of the numbers up to that kind of scientific measurement level. Otherwise, you do get misled. And that is a problem for us, is that because we don't have ways of necessarily confirming some aspects, we have to rely on studies and measurements and analyses, then it's harder and it's easier to become misled, and it's harder to know when you're being misled.
Yeah. So, it's the whole science behind, and this is where Professor Jeremy's expertise is coming, to know what we are measuring and how we are measuring, and what outcomes. You almost like you have to predict the outcomes before you start measuring. Is that correct?
Well, it's always important to have a very good idea of what you expect to find, because really the comparison of what you observe versus what you expected is an important thing. If you go into a circumstance where you don't really know what you expect, then actually you're setting yourself up in some ways for a more complex scenario and a less detailed way of understanding. So really, we need to kind of go in with very, very strict ideas of what we think we should find based on the conceptual understanding of the disease and a treatment, and then you're looking at how the results align with that. And if they don't align, then you have to rethink either your conceptual thinking or your measurement processes. And I think that's something that we do less of. So, for example, when studies are negative, treatment studies are negative, we rarely ask whether it's the measurement processes that have been at fault. So, for example, let's look at some of the clinical trials of treatments that we know have an effect on the disease, and we know from a pathophysiological level should make a difference. Now, if they don't make a difference, then the first interpretation is, well, the treatment doesn't work. A deeper interpretation, which I think is more important, is why is it that we get this result, and what's the reasoning for it? And it's very uncommon for people to question whether their measurement processes were adequate enough for the context of the study that they are running.
So, Jeremy, I find this really complex just to listen to you, and it's not an easy way of assessing the impact, and the quality of the studies, are super important because they are so impactful on our clinical decision-making processes. And we quite often have arguments, or not arguments, but discussions during our MDT meetings. Some of the colleagues would say, I wouldn't use disease modifying for a certain age of people because they read the paper which indicates maybe it's not safe enough, it causes more side effects, and it's sort of the side effects outweighs the benefits. And I understand this is, how we interpret the measurements and how we read the papers and how the trials are being conducted, and how they are very strong, impactful tools for us to make decisions towards patients' health. So how do you interpret these? Maybe let's dwell a little bit on the recent publication about the aging and use of the disease-modifying therapies. I think there are some concerns by the MS community in terms of our decision-making processes. What do you think about?
Yes, I have significant concerns about some of the interpretations. And I think that things can be obviously interpreted at various levels. But I find an interpretation that there's a very binary cutoff about the value of a treatment to be surprising. So it would seem the work saying that there's a above the age of 53 that treatments, MS treatment, disease modifying treatments don't work, does feel to me to be even at a conceptual level surprising to be able to make a judgment like of a nature of that, given that we know that that people differ. So there are some very old looking 53-year-olds, and there are some very young looking and able 53-year-olds, and it would seem curious to lump them all together. And the other thing I feel about the age related stuff is that many people we diagnose with MS in older age groups have evidence of established disease at the time of presentation. So this is the difference between disease onset and disease manifestation. We often talk about diagnosis and symptom onset being at different stages, and it's really difficult to judge the true onset of a disease process. And I think this is something that Gavin has been pointing out significantly, that the way we diagnose diseases doesn't necessarily align well with the fact that they are biological processes. And therefore, a disease process can start when a person is entirely normal in terms of its manifestations. And the point at which the disease becomes manifest varies a lot. So if you have people who are older, whose disease started a long time ago, for which they've not had treatment, then the chances of it being impactful on that disease process are less. So I would like to see a reanalysis of those sorts of data, taking into account an understanding of whether these are people who have presented and have evidence of a new disease process versus those who have an established disease process, and focus in on the different subgroups. Because I suspect that is why we have some of the conflicting results that we do in many studies, and we show that the treatments may appear to have less of an effect than we might think they ought to have. So, and that's, these are selection criteria and looking at really the baseline understanding of individuals when they go into studies. Yeah. So I am concerned that the age-related issues will lead people to be undertreated. That's my concern, and I would like us to see more detailed work on this issue.
The study design is super important. There's statistic models that are being used behind the scenes so that you can measure things. But then if you are failing at the analysis, statistical models, so that gives you skewed data that you misinterpret. And that is very, very misleading, I think, overall. I think there are few trials published in the very impactful journals that really lacks I'm not a statistician, but having discussions and questioning. I think there are some problems, and there are some big problems, I think, overall. And talking about the delay of the diagnosis, I recently conducted within my real world data and at our service, I have to say that the mean of timing of getting the diagnosis in years is 8 years.
Yeah,
we're talking about the 700 people. So it's a huge problem.
It's a massive problem, and we are. And I think this is a broader problem for a lot of neurological diseases. So I think if you look at work in Huntington's disease, where they have a genetic diagnosis and they have a genetic risk. So you can actually take people who have a genetic risk and don't have a disease process, and you can monitor them longitudinally to see those who develop the disease. And my understanding is the recognition is that there are imaging changes in HD well before the diagnosis, a decade, if not longer. And we know also in the dementias, the same, that by the time someone gets a diagnosis of a dementia, they're way down the line of the disease process. And therefore, it makes it so much harder to stop an ingrained disease process. So we, as a community, like you, I think we have to really acknowledge this issue and look at how we can address it. Because by the time someone's had MS for 5 years, 8 years, whatever, then windows of opportunity to maximally impact the long-term impact of the disease are much less.
Yeah.
So that's an area for focus for us, I think.
So I think, Jeremy, what I would like to discuss here as well is how can we personalize patients' journey, because it's very, very individual, So some people come within a year or two, some people come 10 or years later or a few decades later. So let's talk a bit about the personalized medicine in MS, and how are the advancements in measurement tools enhancing personalized medicine approaches for MS patients?
That's a really good question, because most of our work is around group-based information. And so we look at studies and their group-based analyses, et cetera. And part of this is because the individual person measurements are less valid because they have such wide standard errors. So what that means is that when you measure someone and you give them a value, the range of which that value could be, just due to error, can be very wide. And that's a really hard thing. So we've just done some work with the EDSS, and we're presenting it to ACTRIMS next week, showing that the error around EDSS measurements is very, very wide. And it's way past a single category change. So even somebody who has an EDSS of 6, an EDSS of 6.5 and 5.5 is within the margins of error. And if that's the case, then it actually makes it really difficult to interpret some of these circumstances and also to monitor people carefully. So how do we do that? Well, there are assessment methods and measurement methods that allow you to get very precise measurements of individuals. And by precise, I mean you have a value with a very narrow error margin. And then you're in a stronger position to judge whether somebody has changed or whether you're just dealing with variance of error. Those methods are not widely used. They're very complicated. They stem from educational measurement, where they've kind of dealt with the same sorts of issues as us, but they've been ahead of us by a number of decades in terms of the methodological advance. And it will take a while for the clinical community to really embrace some of these very hard to understand processes. Because our measurement, from a clinical measurement and PRO measurement level, we work certainly in terms of the analyses, at a very rudimentary level, against when compared with what is achievable. But what is achievable is very complex for people to assimilate, which makes it very difficult, because these methods require careful study to understand. And that's one of the reasons that I'm here, is that it takes months and months to really of deep study to understand some of this stuff, because it's abstract and it's mathematical and it's complicated. which doesn't help, of course.
No. I'm fascinated to hear that finally we have a formal study assessing the lack of the sensitivity of the EDSS to measure the patient's function. So I'm glad that you mentioned that, and I can't wait to listen to your lecture at ECTRIMS about this. I think we as a community and the providing care clinicians should move away from the EDSS. You know, we are living in the era of the AI shaping the world, and which allow us to personalize patients' unique profile living with MS. And I think it's the time. It's the time to move away from ancient tools that gives you less and less insights on, you know, what's going on in the patient's body and in particular brain.
Yes, it takes us back to a little bit we talked about earlier, is that in 1954, when John Kurtzky produced the DSS for his study of isoniazid as a treatment for MS, it was a perfectly reasonable approach. And then when he advanced that in 1983 to the EDSS, for the time, it was a perfectly reasonable approach. And here we are 41 years later, having advanced. If you think of the advances in our understanding of MS and the complexity and our real focus on some of the more subtle issues, then some of those older instruments do not have the level of precision required to pick apart the differences. And I do think that this is one of the reasons that we've had less success in progressive MS, because we've got slow change, small change over time relatively in the time of a study with an imprecise instrument, trying to look at comparing different groups, and the chances of success conceptually are much less. So that's where I think we've maybe underestimated some of the measurement issues, and it would have been valuable to have a greater a kind of greater investment in those things.
Yeah.
Because if you look at our progressive MS studies, they go back for many, many years, and many of them, if not most of them, were negative, except for the recent Saponamod study. So it's and I think from a patient perspective, this has a moral imperative.
Yeah.
Because we put people in clinical trials, we randomize them to treatment A or B, and yet we use methods that are well described to be suboptimal, and therefore the chances of success are much less.
Yeah.
So
this is super important, I think, and overall, I think you can be the most brilliant healthcare provider in the world, but if you're not measuring for that individual the specifics that are not functioning as they should, and you're not, changing by providing the care specific to that individual, that is not right. So you're failing on both ways. Identifying the cause and then prescribing unnecessary maybe some of the medicine, and then majority of the trials in MS world are still using and utilizing EDSS, and I think this should be also changed. This needs to be changed. We're talking about the clinical and the research world, and they have the link, of course, between the clinical and research. But I think by conducting the more robust design and designing the trials, we may get a better understanding what's going on. And as the management guru Peter Drucker said, only what you get measured, you get managed. So
yeah. No, it's absolutely right. And there are various quotes over the years about we are what we measure, etc., etc. But I think I think that for some things, in particular the clinical parameters, I think what is required to achieve high quality measurements in those areas is not well appreciated, and therefore the methods get less used. And I think we've slightly confounded ourselves with the argument that if you're measuring the same thing, it's good. It enables you to compare across different studies. So one of the arguments for using the EDSS has been that it enables comparison across studies.
Yeah.
But that doesn't help you if it's not a very good measure, because what you lose is all the nuance and the ability to make meaningful comparisons, because all that happens when you don't measure things very well is you don't see differences and you don't pick up changes. You make everybody look the same, and therefore there is no difference. And that's the simplicity, I'm afraid. It's not. And I can see I fully see the argument of having consistency across different scenarios, but actually, I think it's been to our detriment in the long term in retrospect. So,
yeah. So we identified that harmonizing MS measurements across the various research groups is important, but at the same time, you need to use the tool that is sensitive to capture the small deviations. And I think the EDSS really falls to measure the bladder, the fatigue, the cognitive aspect living with MS.
It provides a very useful communication tool between clinicians. So if I say to you, I've got somebody, I saw somebody with an EDSS of 6, you'll have a pretty good idea of that person. You will be able to visualize that person. Whereas if I said to you that they've got a patient-reported outcome score of 50, you won't be able to visualize that person. So the communication aspect of the EDSS has been very valuable, but there's a very big difference between being an assessment method like that and a communication tool and being a measurement instrument for scientific study. So that's and those are really important differences.
Yeah. How can researchers and clinicians navigate these ethical challenges effectively? Is there any way of overcoming these kind of, because people are participating in clinical trials, they get EDSS assessed, and then we're on the other side, we're talking that limitation of the EDSS. So there is a conflict here. So how can we navigate these ethical challenges?
Well, I think that I guess one way is to have really structured, organized research, and you see that less. So it would be sensible if we had really clear initiatives in MS focused on very, very specific things. But we have less of that than we should have. So everybody does their piecemeal research and in a different way, and you've got competing groups, and competitiveness is good, but we have less coordinated research processes. So, for example, if we take you back to the issue of standardized measurements, so it makes a lot of sense to be able to recommend various things for measuring whatever. So let's take, for an example, fatigue. There are 87, or the last time we looked at it, 87 different fatigue measures. 87.
Wow.
So how do you go about choosing one? There are 19 at least that have been used in the clinical studies of MS.
And they all validated?
Well, they've all provide some evidence of their reliability and validity. But we should have a structured process that says, this is a really important aspect of MS that we want to be measuring as well as we can. Therefore, there are planks of work that we should be doing as a community, and we ought to be coordinating this around the globe, or whoever's interested in doing it. We need to be comparing and contrasting these instruments very carefully so that we understand the advantages and the disadvantages of the different ones. And we can advise people under what circumstances instrument A may be better than instrument B. But at the moment, it doesn't happen like that. It happens in a way that someone selects something. They select something because someone else has used it. They select someone for less evidence-based scientific reasons. And by comparing and contrasting the instruments, you start to really dig in deep as to whether they are, what their strengths and limitations are, and also how good they are, and what work is required to try and prove that you're measuring what you think you should be measuring, which is the concept of validity. So we've got another piece that we're just finalizing, comparing lots of different fatigue measures.
Yeah.
And these measures were developed over 25 years, and there's no clear evidence of progression in measurement over that 25 years.
Wow. So we are in stagnation somewhere.
Well, there are various complicated reasons for how these things arise, but one of them is surely before an instrument is published, and if someone says, we developed this instrument because we don't think the other ones are good enough, which is a perfectly valid reason, then surely you compare them against the ones that you say are not good enough or are wanting to demonstrate that the new instrument that you developed is better than that in whatever way it's supposed to be. But for some reason, that type of work doesn't seem to get done.
No. And that's why I enjoy talking to you, Jeremy. And it's another proof after proof. Every conversation is amazing with you, Jeremy, because I get some ideas, and I just got one I can share with you guys. And if you are into research, you need to consider, but I'll give you an idea. I think what we need to do in this world to create a research clinical trial toolbox with the scale of the intensity or sensitivity or specificity of certain tools and measures used in MS, and you categorize and rank these elements, and you produce that on the website maybe. So that would be an amazing opportunity to have that standardized measures that are ranked and could be used in MS research.
Exactly. You have it's a structured approach.
Yeah.
And we should really have a measurement in MS group aimed at these clinical measures. We have less of that than we had. There are some kind of small splinter groups, but there's no coordinated research process. And we should be so we're another issue, quality of life measures.
Yeah.
There's loads of them.
Mm-hmm.
Is there a comparison and a contrasting of the instruments to help the different study design groups to what to choose? Because most study design groups don't have a measurement kind of person in there. A person who's not a statistician, is someone who's really interested, and their focus is on the measurement processes, so they can guide in study development the the best choice of instruments for a particular study when it happens. And that doesn't happen very well as of yet. In the same way, if you go back to the historically to statistics, so medical stats back in the 70s and 80s, you call the statistician in to analyze the data. So you give them the data. They've had no input to it before. So all they do is analyze the data. And quite appropriately, stats has a huge role to play in study design, in power calculations, et cetera, et cetera, et cetera. So we start to see historically statisticians and statistical input right from the early stages of study design. So no longer are they just being given a data set and asked to analyze. They are involved from the off, because actually all the standard operating procedures, the statistical analysis plans are developed during that process of study development, not post hoc.
Yeah.
And the same is required for measurement. But unfortunately, I don't think people fully recognize that there's a difference between measurement and statistics. Statisticians analyze the numbers that are generated. Measurement people like me are interested in the way that we generate the numbers, so that when those numbers are generated, they're as good as they can be for the statisticians to analyze. So measurement is pre-statistics, and they complement each other. And I've never yet seen somebody who's a measurement specialist involved in study design right from the off. You don't see it to the extent that we should be. And so consequently, what happens is people like me get asked, which measure would you use for this study, just when they're about to start the study. Mm-hmm. And you say, well, what do you want to measure? And they go, well, I don't know. We wanted to have a measure of this. And you go, well, what do you mean by this? And what work have you done in the background? And what comparison of instruments have you got? Nothing. And yet we rely on those numbers and analyzing those numbers for all our conclusions. And what you pointed out earlier, these things shape our clinical practice. Yeah. They decide, who's eligible for treatments, what treatments work under what circumstances, how good they are. And yet we've underestimated an area, I think. And I guess we all have our conflict of interest and our belief that certain things are really important. But I do believe that the measurement stuff is way, way more important, and then has been maybe more important and more difficult than has been appreciated.
Absolutely. Yes. Yeah. Well, thank you, Jeremy. I think it's important to understand the implications, and I think just to add on, basically, because I agree totally with everything you just said. But the same is with the radiology input. As we can, present in a few sentences cases, but then when you're actually having discussion and detailed description of the issue, the report suddenly changes. So exactly the way I interpret the measurement is exactly the same issue, isn't it? Like if you're not involved from the beginning, or if you haven't got hands-on type approach on the MRI scan, on the patient, you can't actually produce the report of the changes on the MRI scan. Exactly the same if you are not involved heavily as a measurement specialist or statistician from the beginning of the design of the trial, you can't produce the valid, decent, meaningful assessment and outcomes. So I think it's a very good parallel example in an area that I think clinicians may find easier to comprehend. You're right. Those interactive discussions, those clinical radiological discussions, rather than being given reports or people having to report images with limited clinical information and lack of
lack of the context of where this fits in a patient's journey and their treatment manifestations. It's just, it's a good example because I think they'll find it easier to understand that example than they will to understand the trying to embed the measurement issue discussions right from the off. I think that is taken as being less needed, maybe.
Yeah, totally agree. Okay, so thank you for tuning into this episode of Be Well with MS. I hope you found our discussion with Professor Jeremy Hobart as enlightening and inspiring as I did. I always find really uplifting because it sort of gives me a second thought about the things in life that we do day to day. You never have a chance to reflect, and I think as a community we have to pause and reflect on what we are doing because we are getting into this speedy lifestyle that we all have. Anybody can reach you, you can reach somebody else. There is a non-stop notifications going on your mobile. The production of the papers, articles are very quick. In a week's or two time you can write a paper these days, but the quality of this speed is significantly affected, and we really would need to take that time to reflect, digest, find the right measurement, measure it, and make the impactful changes in people's lives. We are not dealing with the sales, we're not dealing with the marketing. We have to be concrete, accurate, and make the decisions very smart, and there are ways to do that, but we are somewhere trying to find ourselves. And I think with future work and innovations, and by the guidance of Professor Jeremy Hobart and his work, I think we will get to the conclusion that there are tools that are going to be developed by Professor Jeremy Hobart that will be used to conduct very robust, smart clinical trials that will give us a lot of insights, and we will make decisions that will be impactful and changes people's lives. So, Prof. Jeremy's deep knowledge and passion for improving the lives of those with MS through innovative measurement tools and patient-centered care are truly, truly inspiring, uplifting, and gives that sort of a light at the end of the tunnel. It was a privilege, and I have learned a lot from him. I hope his insights will continue to inspire better care. I hope that he will be more available for us to talk to him, although I understand the workload and demand. You're in demand, Jerry, because how many measurement specialists in MS we've got in the world? Probably two, one in Perth and one in Plymouth. But now the one in Plymouth is in Perth.
The guy in Perth is a genius.
Okay.
Absolute genius. And I hope that the MS community will be able to take advantage of his fantastic work. His work is methodological, but and primarily in educational research. And his name is David Andrich, and he's as I say, he's a genius.
Okay, so please follow Professor Jeremy Hobart and David Andrich. Are you both on LinkedIn? We would like to come and follow you. And
probably somewhere.
Okay, we'll find him and share on the notes. Yeah. Don't forget to subscribe for more episodes of Be Well with MS, and feel free to share your thoughts and questions with us. Until next time, take care and be well. Thanks for coming, Jeremy.
Take care, Agne. Bye.
Bye.